Good afternoon, everyone. Today my paper presentation is about a study of Barrett's universal 2 versus SRKT formula to calculate IOL power using immersion ultrasound biometry. Introduction: cataract surgery is considered a refractive procedure, so estimating the IOL power accurately is crucial for cataract surgery refractive outcome. One of the commonly used formula, SRKT formula, that was introduced in 1990 is formulated as a combination of both regression and theoretical approach and has been found to be accurate, particularly in the eyes with axial length more than 27 mm. The Barrett Universal 2 formula, an updated version of BU formula, was introduced in 2010 by Graham D. Barrett and has shown promising results so far. My aim is to compare the predictive accuracy of refractive outcomes after cataract surgery using SRKT and BU2 formula. Objective is to assess the refractive outcome after cataract surgery using SRKT formula and using BU2 formula, and to compare the refractive outcomes after cataract surgery between SRKT and BU2 formula. My study type is cross-sectional analytical study, including 60 patients, 30 patients in each group, and patients were randomized into 2 groups using random tables, and study period is October 2022 to July 2023. Informed consent was taken and done in a tertiary hospital. Inclusion criteria is patient above the age of 50 years, existence of age-related immature cataract based on LOC 3 staging, and no history of previous surgeries. And exclusion criteria is patients excluded with retinal or corneal pathology, traumatic cataract, congenital cataract, glaucoma, squint, corneal degenerations, high corneal astigmatism, that is more than 2.5 diopters per cathometry. Patient demographic details have been recorded, and patients were grouped into Group S and Group B and undergone complete ocular examination, including BCVA, IOP measurement, slit lamp examination, fundoscopy, and biometry were done using IOL power calculation by A-scan ultrasound biometry by immersion method and AIOCMT3. All patients have undergone standard phacoemulsification procedure with 2.8 mm incision and implantation of foldable IOL is done. All surgeries were performed by a single surgeon. Only uneventful surgeries have been included. BCVA is measured at post-operatively at 6 weeks. Refractive error predicted was obtained was tabulated. Comparison of outcomes in both groups was recorded. The collected data was entered, analyzed using Microsoft Excel 2019. The independent sample t-test was used to compare the mean in 2 groups, and Bland-Altman plot was constructed to see the agreement between 2 formula of IOL power calculation. There is no significant difference in the predicted error between SRKT and Barrett Universal 2 group, and there is a significant difference in the obtained error in between the 2 groups. And there is significant difference in between predicted and obtained error in both SRKT and Barrett Universal 2 groups. The Bland-Altman plot was constructed, and there is a positive agreement between the 2 formulas. In the present study, with 60 patients, the conclusion is the Barrett Universal formula provides a better predictivity of IOL power calculation than SRKT formula, whereas in Demian et al., including 34 patients, the study concluded that Barrett Universal 2 formula outperforms both the SRKT and Hedges formula for highly myopic eyes, whereas in Kutimalol et al., 244 patients included, Barrett Universal 2 performed the most accurate formula in the prediction of post-operative refraction over a wide range of axial lengths. Conclusion: the Barrett Universal 2 formula provides a better predictivity of IOL power calculation than the SRKT formula, and clinically helpful for improving the refractive accuracy post-cataract surgery. My limitations of the study is, although immersion ultrasound biometry was used in the study, optical biometry is often preferred for assessing ocular parameters in order to determine IOL power using the BU2 formula. Thank you.
Good afternoon to everyone present here. I'll be presenting on assessment of neutrophil to lymphocyte ratio and platelet to lymphocyte ratio in patients with high myopia. Myopia is a global public health concern. The global prevalence of myopia is estimated to increase by 50% and that of high myopia by 10% in 2050. It's regulated by both genetic and environmental factors, and correlation between high myopia and inflammation has been proposed. Recently, the neutrophil to lymphocyte ratio and platelet to lymphocyte ratio have emerged as new inflammatory markers to evaluate the severity of inflammation. This study aimed to investigate the NLR and PLR in patients with high myopia and non-high myopia to determine whether they could be potential biomarkers in patients with high myopia. Methodology. It was a cross-sectional study conducted at a tertiary care center over a period of 1 year. The patients were divided into two groups. Group 1 had 50 patients who were less than 50 years of age, having myopia of -6 diopters or more, axial length of 26 millimeters or more, and not having any confounding factors that can alter the ratios, such as glaucoma, AMD, or hypertension and diabetes. Group 2 had patients which were enrolled following the same criteria but with non-high myopia and axial length of less than 26 millimeters. Each patient underwent complete ophthalmic and clinical examination. Complete blood counts measurements were performed and the NLR and PLR ratios were calculated. Results. Both the groups were well cross-matched in terms of age and gender, with the mean age of being 24.24 years in group 1 and 26.49 in group 2. We also saw the relationship between the axial length and IOP of group 1 and group 2. The group 1 axial length was 27.44 and in group 2 it was 23.93. The intraocular pressures of both the groups show no significance. Comparison of laboratory parameters between both the groups. In this, the neutrophil to lymphocyte ratio was seen to be higher in the group 1, which is 2.11, and in group 2 1.40, and the platelet to lymphocyte ratio was also higher in group 1, which was 111.25, and the other group 73.75. The study revealed significant differences in NLR and PNLR between the two groups. The NLR of group 1 being 2.11 with 0.27 standard deviation as compared to group 2 with 1.40 with 0.43 standard deviation, and PLR being 111.25 and 73.75 in both the groups respectively, suggesting that high myopia is correlated with systemic inflammation. Also, a positive association was found between the axial length and the ratios. Considering the impact of inflammation on myopia, more frequent ophthalmic screening, more outdoor activities and education are needed to prevent myopia in younger patients with inflammatory or immune diseases, while stronger interventions are needed in those who are already myopic. Conclusion. The neutrophil to lymphocyte ratio and platelet to lymphocyte ratio, which are indicators of systemic inflammatory properties, were significantly elevated in the high myopic group, suggesting that myopia development may be associated with systemic inflammation. Anti-inflammatory drugs and artificial exosomes may become a new option for the treatment of myopia after low-dose atropine. Thank you.
Good morning all. My paper presentation is on a novel Pythagorean-based Android app construction for evaluating surgical induced astigmatism. So the primary aim of this was to design a calculator using Android Studio and study its applications in patients undergoing cataract surgery. The secondary aim is to validate the application using Bland-Altman plots and ROC curve with existing SIA calculator version 2.1. The methods involved, we collected pre and post-operative KH and KV measurements from 107 patients from ongoing dissertation project. The calculator design, the buttons and the interface was made using activity underscore main.xml, and the coding was done in Java file. An SIA magnitude was calculated by taking square root for sum of the kh square and kv square, and axis was calculated by using law of cosines, it's tan inverse function, kv by kh function. The resultant SIA vector was calculated on subtracting pre and post operative SIA vector, magnitude and axis. The results obtained, a total of 107 eyes of 107 patients recruited in this prospective study with a mean age of 62.78 years, consisting of 47.66% males and 52.34% females, with 55 right and 52 left eyes. In percentage, 51.40 and 48.60 respectively. Descriptive statistical analysis and Pearson correlation coefficients for finding association between magnitudes and axis was performed. Pair t-test was done for statistical significance. Histograms were drawn for the magnitude and axis distribution. Scatter plots were designed for finding the best fit line, and Bland-Altman difference plots were used for finding the limits of agreement between the two calculators, and area under curve was calculated on plotting receiver operating characteristic curve. All statistical analysis were performed using Google Colab Notebook. We got an SIA Android app that we made a mean magnitude of 1.31 diopters and mean axis difference of 1.52 degrees. And in SIA existing calculator, the mean magnitude we got was 1.49 diopters and mean axis 91.73 degrees. Pearson correlation revealed a positive association, that is R is equal to 0.38 for the magnitudes, while axis it showed a negative relation of minus 0.08. T-test magnitudes and axis revealed a p-value of 0.35 and 0.00 respectively. Coming to the discussion, a positive skewed distribution observed for both the calculators in magnitude, which implies a similarity in the calculations. As we can see here, a positive skewed distribution in the magnitudes. For the axis, just a symmetrical distribution noted that it implied a difference in axis calculations because of the implementation of vector-based analysis in the existing calculator, and we used tan inverse function in SIA app. A positive correlation was obtained in scatter plots between both axis and magnitude. These all are outliers, and in Bland-Altman difference plot we can see more than 95% of the data, it lies between 1.96 times the standard deviation. It implies a positive correlation, a positive good limits of agreement between the magnitudes, and the receiver operating characteristic curve, it shows a area under curve of 1 and 0.99 for our app and for SIA calculator respectively by logistic regression. So this is the user interface of the Android SIA calculator app, which has already been uploaded in Google Play Store and is readily available for the clinicians for assessing the surgical induced astigmatism instantly. And for the conclusion we drew were that our app and the SIA calculator version 2.1 both are comparable in magnitude calculations, whereas there was difference in axis calculations. Implementing the difference method of calculation, we use the tan inverse function, and in the existing calculator it's the vector based analysis. Thank you. These are my references. Thank you.
So good afternoon, everyone. My name is Neha Batra, and I'm going to talk about the risk factors of progressive myopia and accommodation anomalies among children in North Bengal. I do not have any financial interest in any of the products mentioned in this talk. So we all know that myopia is increasing not just in our Far East Asian countries, but increasing in India as well at a very rapid pace. We have a lot of myopia control options, as in low dose atropine, myopia control glasses, but we still see in our clinic every day that there are children who fail to respond to any of these treatment. So are we forgetting something very basic? In my paper today, I'm going to talk about risk factor management and the treatment of accommodation anomalies in these children. So in my study, children aged 6 to 16 years were taken from our myopia clinic over the past 15 months. And whom did we include? We included only the progressive myopes, that is those children who showed an increase of more than minus 0.5 diopters in the previous 1 year. They had not received any myopia control treatment before, and they did not have any other intraocular disease. Now, whatever is already done in our myopia clinic, the anterior segment examination, axial length measurement, cycloplegic refraction, dilated fundoscopy, along with this, we added 2 more factors. We did the risk factor assessment in the beginning, and we did an orthoptic assessment. So this was our questionnaire, this is the report which was made, and we saw the family history was there or not, or the time spent for near work, screen time, outdoor activities, and sunlight exposure. And among the orthoptic assessment, we did the cover test, near point of convergence and accommodation, accommodative facility, positive and negative relative accommodation, and the accommodative response by the meme method was checked. This is how the orthoptic testing is done by our optometrist in our myopia clinic. Now then we divided it according to whether the children had no accommodative anomaly, a mild lag or a significant lag, where the NPA along with the MAME was increased, or a lead of accommodation where the MAME was in the negative. Now coming to our results, girls and boys were almost equal, 53 to 47. The amount of myopia, most of them had moderate myopia between 3 to 6 diopters. Family history, at least 1/3 of the children had one parent myopic. And among the environmental factors, the total time spent for near work was 6.81 hours, along with additional 1.77 hours for digital devices, but for outdoor activities, only 46 minutes was given. And at least 46% had some kind of accommodation anomaly. Lead was more common than lag. So coming to the discussion, we all know that family history is important, but we always consider it to be a non-modifiable risk factor. But what we want to say is that myopic parents do not just pass on the genes, but they also create a myopogenic environment for their children. So if we can educate these parents, then we can actually make it into a partially modifiable risk factor. We also know from the studies from Singapore, Australia, India, big studies have been done which shows that exposure to green spaces, natural daylight, these are good for children. And more than 45 minutes of sustained near work is bad for children. And what do our children do? Despite knowing all this, 8.58 hours of indoor activity among children in North Bengal, compared to 46 minutes only of outdoor activities. And even when we are educating these parents, they say, my child's lifestyle is too busy. We are really sorry, but it would be difficult to change it because of the academic pressure of today's era. Are the accommodative anomalies important? Yes. They may be the cause, they may be the consequence of myopia, but it is there. And the lag of accommodation has already been stated to be an etiological factor due to the hyperopic defocus that it creates. So we should be correcting this. We should be finding it out in all the progressive myopes, and we should be trying to correct these so that their academic performance improves. And even the performance of low-dose atropine or the myopia control glasses has been shown to be affected, and the fast progressors are those who have these accommodation anomalies. So these should be corrected in each and every child who is attending a myopia clinic. So in our myopia clinic, we see the accommodative status and then go for the treatment. So it is important to educate the parents, change the lifestyle, and go for vision therapy if required before myopia control treatment. These are my references. Thank you very much.
afternoon, everyone. My presentation is on clinical utility of orthokeratology, proficient overnight solution for myopia. Myopia has a tremendous impact on healthcare, not just in terms of vision-threatening eye disease or considerable healthcare cost, but it is going to affect nearly half of the global population by 2050. We try to develop few interventions to halt its progression. Orthokeratology is one of them, in which we use ortho-K lenses, which is a non-surgical procedure that reshapes the cornea overnight and hampers the myopia. This study aims to evaluate the impact of orthokeratology lenses on visual acuity, corneal thickness, axial length in young adults with moderate myopia with or without astigmatism. This study was started on March 2024 in a tertiary eye care hospital. It is an ongoing prospective interventional study. We recruited 120 participants, both male and females, in which myopia was up to -5 diopters with or without -1.5 diopters of astigmatism. Age range was between 15 to 30 years. These were the exclusion criteria, and we use analysis of variance and student t-test for statistical analysis. In pre-fitting evaluation, we did thorough ocular examination of the patient, tear film analysis. Flat K was measured with the help of corneal topograph or op scan, and baseline measurements were uncorrected visual acuity, subjective refraction, corneal thickness, and axial length with the help of IOL master. These were the ortho-K lenses which participants were asked to use for at least 6 to 8 hours overnight. This is the picture this is the picture showing the ideal fit, central flat at least 4 mm zone with mid-peripheral pooling, well-centered lens, and less than 1 mm of migration with each blink. In post-fitting follow-up, we asked the participant to take care of the lens really well, and we measured the pre-set criteria on first day, 10th day, 1 month, and 90th day. In the demography, we had around 65% of the male participant, and rest of the participants were female, and mean age was 21.7 years. Just with 1 day of use of orthokeratology overnight, majority of the patients got clear vision more than 6 to 8 hours. This is the distribution of visual acuity among study participants, and it is the comparison from at each follow-up visit. Most of the patient, 85% of them, reached 6/6 visual acuity at the last follow-up date, which is day 90. And this is the graphical representation of the same, which shows in the initial first follow-up there is not much of an improvement. However, from the second follow-up onwards, there is a continuous improvement in the visual acuity. The same is shown in the logmar chart, which shows there is a decrease in the mean value of the logmar, which shows the improvement in the visual acuity. Also, there is a constant decrease in the standard deviation, which shows the less variability. In the corneal thickness table, we can see there is an increase in the corneal thickness in the peripheral all quadrants, and the central thinning, which is due to the epithelial migration caused by ortho-K lenses. However, the epithelial migration was stopped. It stopped on its own at the end of third follow-up, which was the day 1 month. Day 30th, 1 month follow-up, and there was not much of a change from between day 30th to 90th day of the study. This is the distribution. There is not much of a change in the axial length part also, which could be correspond to the stopped migration of the epithelial cells. To conclude, overnight orthokeratology is a highly effective non-surgical technique for improving visual acuity and controlling axial length progression in patients with moderate myopia and astigmatism. The rapid improvement in visual acuity, stabilization of axial length, and significant change in corneal thickness supports the use of ortho-K as a valuable intervention for myopia management. Though we are presenting only short-term data for this study, it could be a limitation. However, we could get tremendous results with just 3 months of follow-up. Thank you so much.
Good afternoon, everyone. I'm going to present a study on quantitative insufficiency in pre-presbyopic diabetic patients. Accommodation is the mechanism by which the eye changes its refractive power by altering the shape of crystalline lens. During accommodation, ciliary muscles contract, allowing the zonular fibers to relax and the crystalline lens become more convex. Far point moves closer to the eye and to focus on near objects. If crystalline lens elasticity decreases due to aging or diabetes mellitus or any other factors, accommodative response reduces. The maximum accommodation that can be exerted is accommodative amplitude. Presbyopia is a condition which causes reduction in the amplitude of accommodation due to loss of elasticity of fibers. Presbyopia usually occurs after 40 years of age. In this study, the accommodative insufficiency in pre-presbyopic patients with diabetes is measured to know its prevalence, and the amplitude of accommodation between diabetic and normal individuals is compared. Our study is a case control study which included 50 diabetic patients and 50 healthy controls belonging to the age group of 30 to 40 years, and the accommodative amplitude was measured using the minus lens method. Data was analyzed using a 2-sample t-test and a chi-square test to compare the accommodative insufficiency and the amplitude. Minus lens method was done using negative spherical lens which were added until the subject cannot maintain focus. Reduced Snellen's chart was used and the measurement was obtained in diopters. Our study included patients between the age group of 30 and 40, those without diabetic retinopathy, and patients with hypertension and other systemic diseases affecting the eyes, and previous ocular surgeries were excluded from our study. And the Hofstadter formula was used to compare the amplitude of accommodation for a given age. And coming to the results, the table 1 represents the comparison of gender and diabetic status with respect to amplitude of accommodation. Males, the mean value was minus 4.31, and in females, the mean was minus 4.32, and the t-value showed no statistical significance. In diabetics, the mean value was minus 3.73, and in non-diabetics, it was minus 4.84, showing statistical significance. Table 2 represents the accommodative insufficiency according to the gender, and the chi-square test showed no statistical significance here. Table 3 demonstrates the accommodative insufficiency according to diabetic status, and the chi-square test here demonstrated statistical significance. Our key findings of the study are significant reduction in accommodative amplitude in diabetic patients, and the results also show that accommodative insufficiency was independent of gender but dependent on diabetic status. The possible mechanisms could be impact of hyperglycemia on lens elasticity and ciliary muscle function. Microvascular changes in the eye may impair accommodation. Implications are diabetic patients may need earlier corrective interventions for near vision tasks and routine eye examinations for diabetic individuals to detect the early accommodative insufficiency. And I conclude that diabetes accelerates age-related decline in accommodative function in pre-presbyopic patients. Early intervention is the key to preventing further vision deterioration. Here are my references, and thank you.
Good afternoon, everyone. I am presenting the free paper on the topic of the impact of online classes on refractive error among school-going children, a cross-sectional study. Uncorrected refractive error have been major cause of visual impairment in the world. The number of people suffering from the refractive error have been increased over the year. Most concerning population with refractive error in the pediatric children age group. Children already are more likely to develop myopia since there is an increased trend of spending more time indoor using computer and playing video game. The COVID period has been only added to this burden by compelling school-going children to continue their education via online classes. There has been a spike in the number of children presenting to the OPD with complaint of the headache, eye strain, visual disturbance, and the rubbing of the eye. A cross-sectional study was conducted among the school-going children aged 10 to 17 years presenting to the OPD with complaint of visual disturbance and related symptoms between January to March 2023. History was taken about their use of digital device for attending online classes. and the children were attending online classes were selected for the study. A total 116 children were selected for the study. These children were first asked to fill the questionnaire, which consisted of questions pertaining to their use of digital devices. Then these children underwent complete visual assessment, including refractive error by the wet retinoscopy. The data collected was compared to the data from the similar cohort database from the January to March 2019, and results were analyzed. From the January to March 2023, total 178 children presented to OPD with complaint of visual disturbance and asthmatic symptoms. Out of 178, 116 children were willing to be part of the OR study, and from January to March 2019, total 122 children presented to OPD with complaint of visual disturbance, and randomly selected 116 children for the study. This pie chart show in the 2019 and 2023 increase in 35% in the visual disturbance. Out of 116 children, 67 were girls and 33% were boys. And this is a age-wise distribution. There is no such difference. And compare the 2023 and 2019 in symptoms. Asthmatic symptoms are 20% has higher as compared to 2019, and newly diagnosed refractive error has 33%, and worsening of their pre-existing refractive error 41%. This is as compared to 2019 increase in the 2023. This is a pie chart, so increase in the newly diagnosed symptoms and pre-existing refractive error in the 2023, and 38 children were newly diagnosed refractive error have higher in myopia, that is 71%, as compared to 2019. This is pie chart, so in the 2019 and 2023 in myopia incidence, and the 47 children who had worsening of the pre-existing refractive error in 2023, that is also high in myopia in 81% in 2023. And the worsening of the pre-existing refractive error in showing in the pie bar chart. And since the COVID-19 period 2021, 22, and the school children have been increased subjected to online classes. For the screened population, there is only daily online classes are range from the 4 to 8 hours. Their screen has increased, therefore outdoor activity have been increased drastically. Lessened outdoor activity has been known to be significantly associated with higher incidence of myopia in school children. Concerns have been raised about the addiction to the mobile and tablet used by the such young mind, which may worsen in the burden of myopia. From the 2020 to 23, there is almost 35% rise in the number of children presented to OPD with complaint of refractive error and the associated symptoms. In our study, 33% children were previously diagnosed with refractive error, while 41% children had worsening of their pre-existing refractive error, and 27% had asthmatic symptoms. Myopia was a major culprit of all types of refractive error, and the 16% rise in newly diagnosed. Among the all who presented with pre-existing refractive error, there was 50% rise in the pre-existing. Conclusion: there are effective on the online class. Take home message: approach to better shorten the duration of online classes and frequent break, and more importantly, education parent of children about the potential harm of the exposure of the eye, and increase duration of digital screen and method of the curb them, and along with encouragement of the participant in the outdoor activity. Thank you.
So hello everyone. Actually mine is a very simple study, but the study itself is so significant because very often in a medical college where we work, even the residents, even we tend, the patient comes to us for cataract surgery and we say, "Arey, vision bahut acha hai, 6/9, 6/6, 6/12." And we say, "You can come back after some time." But many of these are central cataracts. We know in our history taking, we always ask, vision diminishes in the day versus night, vision diminishes for near versus distance. Why do we ask this? Based on this principle, we did a very simple initiative and just see the differences. So we thought that patients who were driving at night or who were facing glare at night and the vision would suddenly drop. We were not able to diagnose these patients in the dark light settings of our refraction room, because refraction rooms by definition are dark rooms. So in a way, we are giving them more vision and they're actually in their real life facing less vision. So this is why we did this study, bright light testing in a dark room, the real world glare simulation challenge for central cataracts. So common complaints of cataract patients are, we get glare when we are driving in the bright sunlight, or when there's traffic, there's a lot of headlights. So when these patients face disabling glare, they usually show good vision in our refraction rooms. So patients with glare have from headlights or sunlight, usually this is a thing called glare disability, an entity. So this can be due to light scattering within the eye, or it could be due to loss of contrast of the actual retinal image, the image that's following on the retina. So these can be divided roughly into two types, and that is the discomfort from the glare, which is more or less a kind of photophobia discomfort, versus the disability formed from the glare, which is the diminished visual acuity. And this is what we are interested in, that the actual visual acuity also reduces. So this will happen when in central cataracts, because the pupillary size will reduce. So we subjected all these central or the centrally dense cataracts. So PPC, PSC, nuclear cataracts, whichever are centrally more dense, to this test. And what did we do? We simulated, we took a Philips 150 watt headlight and we placed it in our refraction room. So after the normal vision, we put that on. We took a simulated bright light vision, we noted it, we took them to the bright sunlight of our hospital's terrace, and we used the Snellen's chart there the third time. And then we saw whether this can replace or replace the actual sunlight if we can put on just a glare or a headlight in our offices. So it will help us understand whether the patient needs surgery earlier than we thought, whether we should prepone the surgery, and the benefits from the surgery hence. So the aim was to find the correlation of visual acuity taken in the dark to that taken in simulated bright light, and to see this distribution among these central cataracts, which behaves in which way, and to see the correlation whether this corresponded with the sunlight. So we took patients more than 18 years, those with central cataracts, and those without consent or which had other forms of photophobia or other forms of diminution of vision were excluded. So it was a comparative study, observational. We took 71 patients, 108 eyes, lasted for 2 months, and we collected the data after ethics approval. The patient first had a dark light examination, followed by this floodlight. There are no financial interests in Philips, and followed by the sunlight. Then basically the patient had to look at the Snellen's, projected Snellen's, and so the light could not be directly there, so we had a little angulated light. That was just because of logistics. And we saw that we had more males than females. The average age was 58 years. The distribution of cataracts was we had more nuclear cataracts. Among them also we had more of the grade 2 type, the grade 2 nuclear cataracts, followed by PSC, followed by PPC. We saw that just see, this is a log map. So in our normal dark light settings in the blue, the vision is much better. The minute we take it on bright light or sunlight, the vision deteriorates. The diminution of vision increases. This is a log. So diminution of vision increases with the bright light and sunlight. Simply, this is the same thing in in the graphical, two graphical method. So basically we saw that there's a significant difference between dark and bright light evaluation, between dark and sunlight evaluation. And between bright light and sunlight, there was great correlation, very good correlation. So we can use this in our settings. So this is a huge difference between dark and bright versus sunlight, and there's hardly any difference between sunlight and bright light. So basically, this is something I want you all to just, look at. We saw that PPC had the worst drop, 3 lines of drop equivalent to 12 letters. PSC has the least drop. and nucleus sclerosis was somewhere in between with 2 lines of a drop on an average. This was the average of 8 letters. So our conclusion was statistically significant. There is a difference between dark and bright light, between dark and sunlight. There's a very good correlation between the two. The dark cannot, vision acuity in the dark, what we usually do, cannot represent the dangers that the patient is facing, because he may have an accident if his visual acuity drops. And higher the visual disability, his problems in day-to-day life increase. These are missed in the OPD, and this is a good idea to replicate bright light conditions within our office setup. Glare assessment tools, this type of study is very rare, it's hardly been done, and this can be very efficient in understanding the disability due to the glare which is faced by the patient. Thank you.